Muy buenas tardes. Muchas gracias a todos los presentes y esperando que otros más inicien su conexión. Damos la bienvenida a este webinar del proyecto ASI, de leucemias agudas pediátricas. Y es en sí un gran gusto tenerlos a todos ustedes para esta conferencia que nos va a impartir la doctora Priya Kumar. Cuando tuve la oportunidad de la reunión preliminar para solicitarle a la doctora Kumar su participación, le mostré los aspectos generales de nuestro proyecto ASI, armonización de sistemas de inmunofenotipificación, enfocados a unificar todas las fases del proceso para la realización del inmunofenotipo en leucemias agudas pediátricas, enfocados a unificar un reporte armonizado a nivel nacional en México. Le he comentado a la doctora Kumar la heterogeneidad de paneles y plataformas que se tienen en nuestro país para obtener el inmunofenotipo al momento del diagnóstico, lo que puede conllevar a diferencias en los resultados para el diagnóstico. Por ello es que la mesa de paneles de este proyecto ASI, uno de los objetivos es revisar con los expertos a nivel internacional como ella las estrategias para el diseño de los paneles de inmunofenotipo para las leucemias agudas pediátricas y aprender de ellos todos los conocimientos dada su experiencia, sobre todo como referencia internacional en el área de citometría de flujo del laboratorio de la institución que ella coordina, que es, como todos sabemos, el Hospital de San Jude, una de las instituciones que marca la pauta en el diagnóstico y tratamiento de las leucemias agudas a nivel internacional. No dudo que esta participación de la doctora Kumar enriquecerá los conocimientos de cada uno de nosotros para los fines del proyecto, así en bien del diagnóstico correcto y confiable de las enfermedades hematológicas neoplásicas en los niños de este país. Tengo el gusto de presentar a la doctora Priya Kumar, quien es doctora en medicina por la Escuela de Medicina para la Salud Internacional. Hizo su residencia en anatomía patológica y clínica en el Cedars-Sinai Medical Center de Los Ángeles, California. Ella, su fellowship lo realizó en el Memorial Sloan Kettering Center de Nueva York, en hematopatología. No sobra decir que tiene una gran cantidad de trabajos publicados de las investigaciones que se hacen en el campo de la hematopatología y que sus principales líneas de investigación son el panorama inmunológico de las neoplasias hematológicas y algo que me llamó mucho la atención es el desarrollo de las capacidades de diagnóstico innovadoras en entornos con recursos limitados como una de sus líneas de trabajo. Sin más preámbulo, tengo el gusto de presentar a la doctora Priya Kumar con la plática Citometría de flujo diagnóstica en leucemias pediátricas, la experiencia del Hospital San Jude de Memphis, Tennessee. Doctora, muchas gracias.
Great. All right. Can you guys hear me? Great. So I'm going to talk to you guys about diagnostic flow cytometry in the setting of childhood leukemia. I'm part of the Global Pathology and Laboratory Medicine program here at St. Jude. That is a program within Global Pediatric Medicine here. So what is the purpose of multi-parameter flow cytometry? It's a process and a tool to characterize hematolymphoid populations in a variety of different human tissues, including bone marrow, peripheral blood, tissues, or body fluid. Its main use is to determine lineage. On the right-hand side, you can see morphologic correlates of various precursor cells. However, while I can clearly tell the difference between a blast cell and a megakaryocyte right here, if you have sheets of blasts in the case of acute leukemia, it can be nearly impossible to tell the difference between a myeloid stem cell here or a lymphoid stem cell. So the power of this method comes from the ability to analyze the expression of multiple different antigens at the same time on each analyzed cell. It's helpful to determine the exact type and subtype of leukemia and to confirm a suspected diagnosis, or at least to narrow down a differential. The frequent turnaround time can be within hours to 3 days. In current clinical practice, this typically entails using a flow cytometer machine. In a single clinical lab, you should ideally have 2 of the same machine so that if one machine breaks down or is broken, you can have the other one as a backup. Each flow cytometer has a set amount of fluorescent antibodies that you can be added within a single reaction tube, or you can have 3-color flow cytometry, 4-color flow cytometry, 8 or 10-color flow cytometry as well. In addition to the number of antibodies, one typically also records 2 light scatter parameters for each event, so-called forward scatter and side scatter. Meaning if you have a 4-color flow cytometer, for example, each individual cell, you collect 6 discrete pieces of information. Before you look at antibody expression on each cell, you use a 2-dimensional plot here to plot forward and side scatter. And you can use this gate to exclude debris on the far left-hand side to create a pseudo-Ficol gate if you would like you see here. Next, you look at each parameter with width and height. On the right, you see a schematic of a flow cytometer, the blue arrow being the direction of flow of each cell. So usually, one cell goes down the flow cytometer one at a time. However, sometimes it can be sticky and you get 2 cells at the same time, which can skew the area versus height. And you use this to exclude any doublets here. So we call this gate our singlet gate. You do this again vertically to exclude any doublet cells that might be going in at a vertical orientation, and sequentially gating this way allows you to come up with a denominator of non-debris, non-doublet cells, out of which you can calculate your population of interest that you're trying to report as a percentage. After acquiring several cells, you can start to see clusters of cells that correspond to biologically distinct populations in vivo. Analysis of these clusters is a process that can be likened to morphologic analysis using a light microscope. And in fact, that's the first step of any flow cytometry assay. You make a slide and look at it morphologically. So normal populations produce characteristic qualitative clustering patterns that can be used as a baseline assessment of abnormal, whether it's expanded or low numbers of populations that you're seeing. The first plot that you look at often is a CD45 side scatter plot, like you see here. The interest gate, which is where your myeloblasts or hematogones usually sit, is here in the CD45 dim low side scatter. Granulocytes, which are CD45 dim and very high side scatter. Mature lymphocytes sit here at the mature bright CD45 and low side scatter, and bright CD45 moderate side scatter is your monocytes here in green. When analyzing, it can be very useful to always use the same color to represent each population so you can start to recognize patterns. So hematologic malignancies account for about 1/3 of pediatric cancer cases. Applications of flow cytometry to the pediatric hematopathology arena are largely the same as you would see in general hematopathology, with a few key differences. The table here on the right excludes any assays that are performed for congenital or acquired immunodeficiency states, such as ALPS studies or TMB lymphocyte studies, or flow cytometry evaluation for familial HLH. Here are the most common uses, though. On the top, you have diagnostic assays for acute leukemia and mature B-cell neoplasms, MRD evaluation in the middle, and DNA index on the bottom. This is mainly for BALL diagnoses or neuroblastomas. You can rule out several of your differentials if you're dealing solely with the pediatric population. As such, you can sort of exclude multiple myeloma or PNH, which are very rare in this population. The most common heme malignancy is acute leukemia, mainly B-ALL. Mature B-cell neoplasms are usually either Burkitt lymphoma or DLBCL. Mature B-cell neoplasms like chronic lymphocytic leukemia are not going to be in this age group, and it's important to identify these differences because now, excluding CLL, you won't have to design a tube that has CD19 and CD5 in it, for example. Lastly, each of these applications require a different setup, a different processing method, and a different gating strategy. So if you're trying to make a first diagnosis, you can't use a rare event assay like MRD evaluation. So as such, diagnostic flow assays are not screening assays and are not ideally suited for a rule-out leukemia clinical situation. Diagnostic assays are processed differently. They acquire many less events than an MRD assay, for example. And from here on out, we're going to focus on acute leukemias since they're the most frequent diagnostic subset in this age group. So if we go back to the basics, acute leukemia is a clonal hematopoietic process, and flow cytometry can help you identify homogeneous clusters or populations of cells based on the scatter properties and antigen expression to help determine the lineage, either by identifying an expanded population of cells that are arrested or stopped at a normal stage of development like APL or acute promyelocytic leukemia, or it can identify cells that have aberrantly or abnormally differentiated by expressing abnormal antigens or a leukemia or so-called leukemia-associated immunophenotype or LAIP. Flow cytometry patterns can help suggest some cytogenetic or molecular aberrations as a clue to classification, and it can also help you identify mixed phenotype acute leukemias. In 2011, the European Leukemia Net, or ELN, working group aimed at establishing a consensus on the required reagents for proper immunophenotyping of acute leukemia and lymphoproliferative disorders. So for a quick orientation, or in cellular samples, for example, they recommended a limited set of antigens, including CD45, which is a marker you need in almost every tube you design for gating purposes, as well as a set of cytoplasmic markers, including cytoplasmic CD3, cytoplasmic MPO, and cytoplasmic CD79A. Then they proposed a second set of differentiation antigens to confirm the diagnosis. They also proposed that at least 2 of different antigens of each lineage should be present to call it. So non-lineage specific antigens such as CD34, HLA-DR, CD10, CD56, or TDT wouldn't help you determine your lineage. They might help you determine aberrancy or immaturity. Myeloid antigens are listed here CD117, CD33, CD13, etc. B lineage markers are here. PAX5 is usually the most specific. However, it's not usually available as a flow marker, and you're most likely going to see it as an IHC marker. T lineage are these, and megakaryocytic erythroid lineage are CD41, CD61, and cytoplasmic CD42b, glycophorin A being an erythroid lineage marker. So here at St. Jude, our workflow for a new leukemia starts when a new patient with suspected leukemia presents to St. Jude. The pathologist first confirms then that they see an adequate amount of blasts on the smear of the sample being tested. The diagnostic procedure consists of several tubes that are taken to various different laboratories. So a purple top tube goes to, one purple top tube goes to the core lab, one goes to special hematology, and another goes to the molecular lab. The immunopathology lab or the flow cytometry lab receives a green top tube, as does the cytogenetics lab. It's important to emphasize that that first step was someone confirming that the sample did indeed have enough blasts, so that when these individual laboratories get their sample, they can automatically initiate their workflow. The IP lab can run the right assay, the cytogenetics can set up their chromosomes, molecular can extract their DNA, and it minimizes any wasted workflow or false negatives due to sampling error. So let's focus on the tube that goes to the IP lab, which is a green top heparin tube. So we then, the IP lab then confirms or sets up a diagnostic panel to confirm lineage. And based on the lineage, we then perform a comprehensive diagnostic panel designed to identify a leukemia-associated phenotype for that specific lineage. Our initial diagnostic panel for lineage assignment is seen here. It includes 4 different intercellular markers, seen here in 3 tubes, as well as 44 different surface markers in 10 tubes, seen here. 2 of our tubes here are taken up by IgG controls, IgG1 here and IgG2 here. And this allows us to assess staining properties and compare whether what we think is positive staining is truly positive above any background or non-specific staining that might be caught by these markers. Our comprehensive testing after lineage assignment is to assess a suitable strategy for MRD. And it consists of 9 tubes for BALL, 8 tubes for TALL, and 7 tubes for AML. So in the case of BALL, for example, our lineage assignment was B, and so we perform a set of 9 tubes. There's a backbone of 5 markers, meaning these markers are present in each and every single tube, and the same is true for our AMLs and our TALL MRD panels. We have a backbone of markers that are present in each tube. For BALL, these markers are CD34, CD10, CD22, CD45, and CD19. We then have a group of 16 markers that can identify a unique marker combination that are often aberrant, such as CD38 decreased or aberrant expression of CD123, NG2, CD13, or CD33. So in summary, when one new patient comes with a suspected leukemia, at our institution, we perform a panel of 48 markers plus 4 extra markers in 13 tubes. We then perform an extra 7 to 9 tubes with 27 markers, and then pick 2 of those tubes that are the best combination to perform at future MRD time points. And this can be up to 1,600 cases per year. So is this practical in all settings? The more markers means more technical skills, more controls, more markers to interpret. And it may not make sense if your particular center only sees a fraction of the cases that we do. The theoretical best combination to determine lineage, if that's your question, is includes 3 cytoplasmic markers, like we talked about before: cytoplasmic MPO, cytoplasmic CD79A, and cytoplasmic 3. These are present in some panel proposals, but are not fully applied in practice and not nearly enough. So depending on the number of antibodies in your flow cytometer, that your flow cytometer has, whether it's a 4-color instrument, an 8-color instrument, a 10-color instrument, you can use these markers and then add as many markers as you have. So this is a theoretical limited immunophenotyping panel that we can compare our future cases to. So let's start with the most common type of acute leukemia in the pediatric population, which is lymphoblastic leukemias. They can be classified according to B or T lineage, and they are classified according to maturation: pre, pro, and the most mature. Many similarities exist between these 2 lineages. They display an early committed progenitor cell or common lymphoid progenitor. They display antigen receptor rearrangements like IgH and TCR rearrangements, and they also undergo antigen selection. The major marker for B lineage is CD19, and the major marker for T lineage is cytoplasmic CD3. When you consider B lymphoblastic leukemia, the common differentials are listed here. There's a high percentage of hematogones that can normally occur in pediatric marrows, and this fact, it may be difficult to distinguish by morphology alone hematogones versus leukemic cells. Here you can see different types of morphologic lymphoid blasts. On the left, you can see L1 type blasts, which have a more immature stem cell-like features. L2 type blasts have a little bit more cytoplasm. They might look more like a myeloid blast per se. And L3 type blasts, they're a little bit larger with vacuolations, and they can look like Burkitt cells in Burkitt lymphoma. Fortunately, hematogones, myeloid blasts, and Burkitt cells have distinct flow characteristics that can greatly aid in the distinction between these differentials. So keeping these differentials in mind, how do we diagnose BALL? You have to ask yourself 3 questions. Is it immature? Is it B lineage? And is it aberrant or different from a normal hematogone? So for immaturity, morphology can help you, but also flow characteristics include: does it fall in the blast gate? Is it dim for CD45 and low side scatter? Does it fall in that interest gate? Does it express CD34? Does it express TDT? Does it have no surface light chains like kappa or lambda? And if it's CD19 but without 20. B lineage markers are listed here. And to prove B lineage, you want to see more than 1 B cell marker on the cell, but also negative for T cell markers like cytoplasmic CD3 and cytoplasmic MPO. And lastly, you want to see if it's aberrant, different from normal hematogones. Just by seeing an expanded population itself is an abnormal clue. It can aberrantly express myeloid antigens like 66C, CD123, CD33, for example, or it can express abnormal maturation. So if it has CD34, but also with a mature marker, CD20, that can be abnormal, proof of abnormality. If it's negative for CD45 or overlapping with debris, that's also an abnormality. CD10 can be way too bright, or CD38 can be decreased from normal. In 2001, Steve Croft and his group described the typical pattern of hematogones using a 4-color panel. So here you can see on the dot plot, using the CD19 and CD10 plot, the dark blue population represents the most mature B cells. The green are intermediate, and the earliest ones are shown in pink, being the 10 brightest. You can see as the hematogones mature, they lose 34, lose 30, 38, they gain CD20 and go from being dim CD22 to bright CD22. So here is a real case of BALL seen here at St. Jude, using our diagnostic panel. Forgive me, like I purposely put very junky data for this presentation and not the cleaned up versions that you usually publish in journals, because even here at St. Jude, there is background staining and non-specific staining that can confound results. So, but you can still tell a lot from your flow data. Here, CD45 and side scatter plot, you can already see there's an expanded population here that is CD45 negative. It's overlapping the debris and it's below these CD45 dim granulocytes. You can see that it is positive for CD34 here. It does not express any surface light chains. It expresses CD19, CD22 here, and it has partial CD20. And it also aberrantly expresses CD123, partial CD33, and the CD10 is way too bright over here. So let's come back to the theoretical limited panel that we proposed. The case prior would have been CD79A positive, MPO negative, cytoplasmic CD3 negative, 45 negative, CD10 way too bright, CD34 positive, CD19 positive, and CD3 surface negative. So you would have had proof of B lineage, immaturity, and aberrancy all in one tube. Next, let's say at your institution, you utilize MRD by flow to influence your treatment decision tree. You can then decide on a panel like the second one to determine what markers you can follow. You can use markers that are not present in normal hematopoiesis like NG2 or TSLPR. If your institution, for example, had a directed antibody therapy to CD33, you could replace CD13 with CD33 here. The possibilities are endless, but these are two tubes versus the 13 tubes that we started out with. If your differential, for example, was BALL versus Burkitt lymphoma, so say your original case was 34 negative, for example, or you have a clinical history of a abdominal mass, or on the slide, it actually looked like L3 type blasts. You might want to use a second panel here and assess for lambda or kappa light chain restriction, whether or not it expresses CD20, and whether or not it expresses TDT. It's really important to emphasize that in this context for lymphomas, large B-cell lymphoma, either DLBCL or Burkitt lymphoma, the diagnosis should always be made on FFPE or morphology, not by flow cytometry. By flow cytometry, your top line should be monotypic CD10 positive B-cell lymphoma, and then reference the pathology report. So next, let's talk about lymphoblastic leukemia T lineage. The common differentials in this patient population are listed here, either thymoma. Mature T-cell lymphomas are quite rare in this population, but you can also have a NK cell expansion due to a chronic active EBV, So clinical history will help you here, and considering if the patient has a mediastinal mass, your differential could be thymoma versus TALL. If you have high serum EBV titers, your differential could be TALL versus mature T-cell lymphoma, or a chronic active EBV or an NK cell expansion. So the diagnostic criteria for TALL are similar to B, however, there's one caveat. In the peripheral blood and bone marrow aspirates, there's no normal immature T cells. So in that situation, the only two factors that you need to satisfy are, is it T lineage and is it immature? And then you're done if it occurs in the PB or the bone marrow. So is it T lineage and not NK cells? NK cells can express cytoplasmic CD3, but they're not surface 3. They're surface 3 negative and 5 negative. And is it immature? Clues to immaturity could be cytoplasmic CD3 without surface CD3. It could be CD45 dim, TDT expression, CD117 expression, 34, or 1A. If you're looking at a tissue and you are analyzing a tissue by flow cytometry, like a mediastinal mass or a mediastinal lymph node, you have to distinguish it from normal T cell maturation that occurs in the thymus. So the third diagnostic criteria, meaning aberrant from normal, is assessed on mediastinal masses. Here you can see the earliest T cell precursors are highlighted in orange. Red are the intermediate, and blue and green are the most mature. So the T cells start out double negative for CD4 and CD8. They turn double positive for CD4, CD8, and then lose one or the other as they mature. The earliest T cell precursors are surface CD3 negative. They gain and lose CD1A once surface CD3 is gained. And CD2 and CD7 are expressed much earlier than surface CD3, with the earliest precursors being the brightest for CD7. Because of the difference in incidence compared to the adult population, institutions that serve both adult and the pediatric population often have a surface only approach to evaluating for T cell lymphomas. TALL specifically can be missed by using a surface CD3 as the first discriminating gate to assess for mature T cell lymphomas. So if you have such a gate, if your institution does assess for both T cell adults and pediatrics, you could adopt a discriminatory gate that first includes CD2 and CD7 expression, and this will allow you to evaluate for both scenarios. This is an example of a TALL unit using how it appears on a surface-only panel of markers. So here at St. Jude, we were presented with a 5-year-old female with a pericardial effusion. So first, the CD45 and side scatter plot, you can see there is an expanded blast population in the interest gate in red. These cells are cytoplasmic CD3 positive and negative for MPO. They're also, I didn't show to you, they're also negative for CD19. These cells are partial for CD3. They are CD2 positive, CD5 positive, TDT positive, and CD79A positive. CD10 is also CD1A is positive in a small subset here. So let's go back to the limited panel and see how good it did at diagnosing this without so many markers. So we would have seen that it would be positive for CD79A, negative for MPO, positive for cytoplasmic CD3, CD45 would have been dim, CD10 would be positive, CD34 would have been negative, CD19 would have been negative, and CD3 would have been partial positive. So you already have T lineage, not B or myeloid. You have immaturity through dim CD45 and CD10 in this example. And in the context of a TALL, expression of CD79A is aberrant or a sign of aberrancy. So other considerations are if your particular institution treats ETP differently, the next two panels could help stratify or rule in or rule out an ETP. And perhaps if the clinical history had a high serum EBV titer, or you're suspecting an NK cell morphology, you can use this panel to rule out an NK lineage. Finally, let's talk about acute myeloid leukemias, which are a little bit less cut and dry. It can be classified according to maturation stages. However, just one marker of lineage, like cytoplasmic MPO, is not specific or sensitive enough. No MPO in itself, even if it's negative, it could still be AML with minimal differentiation. It could be a monocytic leukemia or a megakaryocytic leukemia, all of which are MPO negative. The specificity of a myeloid lineage does increase with a group of markers. So for example, if you have a group of CD34, 117, 13, and 33, you're more likely to have a myeloid lineage. So the differential diagnoses includes myeloid hyperplasia, either post-viral infection or post-medication. APL is a special consideration in this group. You could have a myeloproliferative disorder like CML or JMML, and you're evaluating for blasts in that situation, or metastatic solid tumor, like this is an example of a metastatic rhabdomyosarcoma. So MPNs need very critical correlation with serial CBC values and trends and clinical suspicion, and flow cytometry alone is not going to make your diagnosis there. Circulating solid tumors will be CD45 negative, and they'll appear much larger and in clusters on morphology. So when diagnosing, if you have sheets of blasts and you're trying to diagnose acute myeloid leukemia, you have to ask yourself the same three questions. Is it immature? Is it myeloid? Is it aberrant from normal regenerative myeloblasts? So immaturity morphology can help you. The dim CD45 gate can help you. 34117 can help you prove immaturity. If in the case of a monocytic lineage, if it expresses CD64 but without CD14, that's also a sign of immaturity. TDT is expressed in some AMLs with minimal differentiation, and CD123 is also immature. Is it myeloid? Meaning, does it express all of these antigens, but also necessarily negative for cytoplasmic CD3 and CD19, for example? And is it aberrant? Different things can prove aberrancy in the myeloid population. It could be a maturational abnormality, like having both mature markers and immature markers at the same time, like CD15 with CD34 or CD11B with CD34. It could also be two markers that should be together or apart. So CD34 without HLA-DR would be aberrant, or they could be truly atypical, like expressing T cell markers like 2, 5, or 7, or expressing an NK cell marker like CD56. So here is a in-house case, a 7-year-old male with a history of fever and a high WBC count. Starting with the CD45 side scatter plot, you not only see an expanded blast population here, but you can also see that you have a neutropenia. The granulocyte gate doesn't have nearly as many as you would normally see. So you see two abnormalities just by this first plot. You see immature markers like CD34, CD133 here, CD123. You see myeloid expressing markers like cytoplasmic MPO and CD33 and CD15. And you see aberrancy. CD34 expression and CD15 expression, for example, is aberrant, as well as HLA-DR being negative. APL is a special case within this diagnosis and can be a diagnostic emergency. The cells are arrested at the promyelocytic phase, and if you can recognize the typical morphologic appearance and immunophenotype, you can suggest further confirmatory testing or additional treatment in the meantime. So as other confirmatory or ancillary tests are available, they still have a higher turnaround time than flow. So it does become really important to be able to identify. So the typical immunophenotype for APL is a high side scatter, meaning it overlaps with what you would normally see in a granulocyte gate. They're positive for CD117, 33, and strong MPO, and they're negative for CD34 and HLA-DR. Obviously, not every leukemia reads the book, but you can definitely generate workflows to suggest reflex testing in cases of suspicion. So instead of taking you to our original limited panel, I wanted to share our experience at a separate center in the CASA region, where at the beginning of our partnership with them, they had a fax caliber 4-color machine. They were using a combination here of 26 antibodies in 16 different tubes that were only taking advantage of 3 out of their 4 available channels and 1 out of their 2 available lasers in their machine. So in order to design a panel that was a more efficient use of their resources, we developed an assay with 3 different tubes and 7 different antibodies, taking full advantage of all 4 of their fluorochromes. In our previous case, that initial panel would have been negative for TDT, negative for cytoplasmic CD3, negative for CD19, positive for CD34, and positive for MPO. So your decision would have been towards AML after that first panel. So in the situation where your morphologic consideration was for APL, we proposed the top additional 4 tubes with IgG controls. And likewise, for other potential subtypes of AML like M7, we developed the lower panel for including IgG controls here. This simplified panel and standard approach has multiple advantages. From the tech's perspective, it's much simpler and manageable to process and stain these samples. And from the pathologist or the hemato-oncologist perspective, the interpretation becomes that much easier and simpler because you're looking at less antibodies, and all of this without sacrificing any of the diagnostic power. Other considerations when deciding on panels is what genetic subtypes may be of clinical significance or change therapeutic decisions at your specific institution. So expression of the following markers by flow cytometry can suggest certain genetic alterations and may highlight a workflow for reflexing only a subset of cases for genetic testing instead of like a wholesale approach and just genetic testing on everything. Listed here, you can see TSLPR expression is suggestive of a CRLF2 rearrangement, and G2 overexpression can also be suggestive of a KMT2A or MLL rearranged case. A group of expression markers of a BALL with CD15 expression and CD10 negative can also suggest an MLL rearrangement in the context of BALL. The expression of these 3 markers can suggest a TCF3 PBX1 fusion. Aberrant markers like 13 and or 33 can be suggestive of ETV6 RUNX1. Also, a combination of 26 CD27 expression and CD44 negativity can also suggest this subtype. APL, like discussed before, has a very specific specific and sensitive immunophenotype. If it's otherwise AML but has CD19 expression, it can suggest a translocation 821. Down syndrome, myeloid neoplasms associated with Down syndrome can express megakaryocytic markers and also CD7 and CD56. Co-expression of 2 and 371 in BALL can suggest a DUX4 rearrangement. It's important to note that even when using these markers, some markers like TSLPR and G2, while specific for these rearrangements, they don't have normal internal positive controls that you can use within your samples. And so to routinely use them in your clinical report for clinical reporting in your lab, you'll need to attain either cell lines or buy commercially available positive controls. And other ways we can take St. Jude's experience to suggest limited workflows is by looking at the diagnostic accuracy of certain samples. So between 2012 and 2016 at our institution, we performed an IP panel on 108 BALLs, 57 TALLs, 116 AMLs, and 9 MPAL cases. Sampling of the peripheral blood gave us the same answer as sampling in the bone marrow in 98% of our cases, with key exceptions. The diagnoses with the highest frequency of discrepancy were acute megakaryocytic leukemia, mixed phenotype acute leukemia, and early T-cell precursor leukemia, or ETP. So to diagnose ETP, you need the following. It has a unique phenotype that includes both myeloid lineage markers, and it's a very immature T-cell phenotype. So they have cytoplasmic CD3, but no surface CD3. They are necessarily absent for MPO staining. They are negative for CD1A and CD8, and more than 25% of the blasts should express a stem cell or myeloid marker like CD34, CD117, CD13, CD65, etc., and dim to negative CD5. CD5, if more than 75% of the blasts express ETP, you can diagnose a so-called near ETP phenotype. MPO expression has a long history, and it's worth looking at since it is the main crux of your difference between ETP and MPAL, and it could cause significant changes in your treatment decision. So cytochemistry detection of enzymatic activity within the cell can be used to determine whether there is MPO expression in your leukemic blasts from a morphologic perspective. While this is a really old method, here at St. Jude, we still perform it. And we perform a cytochemical MPO stain on all of our new ALLs. The cutoff for this stain at most labs that use it is around 3%. So 3 blasts have to be positive out of 100 blasts. Several reports on the other labs, or another acceptable method of determining MPO expression is by flow cytometry. Various labs determine expression in different ways. Some compare it to our isotype controls like IgG. Some compare it to normal negative controls like mature lymphocytes. Some compare it to normal positive controls like mature granulocytes. The cutoffs range from 5 to 10%, depending on your lab, and each lab has to validate it separately. Expression can be difficult to assess, and isolated expression of MPO doesn't necessarily mean MPAL. And as in the case of BALL, you can have BALL with isolated MPO expression. So how do you diagnose MPAL? The latest version of the WHO reads like this. And the take-home points from this are that these rules are not for lineage assignment, but only for cases where you suspect a mixed phenotype of acute leukemia do you use these rules. So it can be one population that expresses antigen from 2 different lineages, or it could be 2 separate populations that each reach their own definitions for acute leukemia. So this is an example of a case where the PD flow cytometry falsely suggested a diagnosis of ETP in a patient who was found in the bone marrow to have MPAL, T myeloid. By flow cytometry in the PB, here you can see an expanded interest population here, 45 dim, low side scatter, that was consistent with ETP based on the expression of cytoplasmic CD3 here, less than 5% MPO expression, lack of CD1A expression, CD5 in less than 75% of the blasts, no CD8, and expression of CD33 and 34. In the bone marrow, however, MPO and flow cytometry showed about 10% of the blasts expressed MPO, and not only that, the myeloid blasts themselves expressed an aberrant phenotype, including CD11B and CD34 on the same population. So in this particular case, after treatment with an ALL type of regimen, the patient relapsed as a pure myeloid leukemia with a complete loss of cytoplasmic CD3 expression. So identifying these cases can be really important. In this case, the flow cytometry in the PB falsely suggested a diagnosis of AMKL. In this patient, you can see the CD45 dim to negative population demonstrates really intense staining of CD41 and CD42 expression. And only a minor population here, non-specific, doesn't really form a homogeneous cluster in the CD19, CD10, CD33 arena here. Subsequent bone marrow evaluation of the same patient was found to have B-ALL. So here you can see the CD45 was negative to dim. CD41 and CD42B were pretty cleanly negative. CD79A, CD22, CD10, CD19 were positive. It was immature, TDT, and aberrant. It expressed CD33. In hindsight, you can probably see a minority of those events in the peripheral blood, but the sampling was just not there. So this also highlights the importance of having an adequate sample. Acute megakaryocytic leukemia falls under the umbrella of acute myeloid leukemia. It is enriched in the pediatric population as opposed to the adult population where it's really rare. Blasts can be very sticky, and markers used to identify megakaryocytic lineage can be very non-specific and identify platelets like we saw in the last case. So because of these reasons, bone marrow evaluation with a good core biopsy is the proper method to evaluate for suspicion of AMKL and for future follow-up. AMKL is usually negative for HLA-DR, positive for these markers listed here. And on morphology, you can see a characteristic blebbing of the cytoplasm here. So finally, there is going to be some variability across labs. While panels and gating strategies can be standardized, variability can be introduced by machines. It can be operator dependent, antibody availability, sample variability, and even patient variability. So more antibodies is not always the better solution as they introduce more complexity in testing and in interpretation. So we come back to the question, is comprehensive panel testing necessary for your lab or region? While there's no real easy answer, onboarding new assays always require a give and a take. More information comes at the expense of more opportunity for error. And a few considerations listed here can help you make the decision to include or exclude a certain marker depending on the reasons for your specific lab. So to help standardize approaches, implementing rules can really help. Always, always, always start with a clinical history and differential diagnosis. I know for the clinicians in the audience right now, when you're ordering a flow cytometry test, please, please, please fill out the order reason or the clinical history as best you can, because narrowing down the question will decrease waste in reagents and wasted assays, but it'll also increase the opportunity for a solid diagnosis at the end. Then always question whether your sample is adequate for the question you're asking. If you're testing a bone marrow aspirate, did you look at the morphology, make sure that there are spicules that you're inside the bone marrow? You might be just have a sampling error, or you might have a hemodiluted sample, for example. And also break down your mental process and break down your logic. Is there an expanded blast population? Great, I'm trying to determine lineage. If it's CD19 positive, then go this route. If it's cytoplasmic CD3 positive, then go this route. If it's MPO and 33 positive, then go another route. The only, in your flow cytometry plots, it is better to only show the populations that are of interest, and always, always, always use controls. Several rules for reporting. You should always report your population of interest as a percentage of either total WBCs or total mononuclear cells, depending on your lab, but it should always be the same, depending on, it should always be the same coming from the same lab. And you should report viability as a good quality metric. The viability of this sample, either by various methods, it doesn't matter. So, like we decided before, flow cytometric patterns can help you suggest other workflows, and it can, but you have to consider the turnaround time and the cost of other ancillary methods to determine the best use of your resources. So here you can see a comparison of techniques and really make the decision based on cost and turnaround time. So finally, you start making a diagnosis with the morphology. You add in flow cytometric analysis. You can add cytogenetics. You can add molecular information, all in an effort to make a very comprehensive, integrated diagnostic final line. So with that, I will take any questions.
Dr. Kumar, I think that there's a question in the chat.
Sure.
Hay una
We'll write it for you. Okay.
pregunta en el chat y que dice en relación a los linfocitos B, sabemos que los blastos inmaduros expresan CD19 desde la etapa pro-B. ¿Podríamos interpretar que estos blastos de LLA son células pro-B con propiedades leucémicas o simplemente linfoblastos inmaduros que expresan CD19 debido a las características intrínsecas de la LLAB? Es una pregunta que no está en el chat.
Yes. So there are different ways to prove aberrancy from normal pro-B lymphocytes. So it can first, like I've seen in normal pediatric marrows up to 20% blasts in the case of a child getting over a recent viral infection and or others. So the clinical history can help you. But also there are different ways. So if it's an expanded blast population, say 40%, 50%, 60% in hematogones circulating in your PB, you're already at abnormal. You can't, hematogones don't normally circulate in the peripheral blood. You can also have different context clues, like here. Am I still sharing or here? My favorite plot. My favorite plot to decide on difference from normal hematogones from the stages is the 1910 plot. If you see a expanded population in either of these scenarios, if you see 20 but with 34, that should never happen. So if you see any abnormal population here in this area, if you, for example, see CD19, CD10, but your 38 is way down here, that should also kind of spark this is not abnormal, this is not normal. And if you are worried about that distinction, you can use CD9, like at your institution, always have these plots: CD19, CD10, CD20, CD10, and CD34, CD20, and CD38, CD20. If you always have these plots on your worksheet, you get to first understand where normal ones, but then you'll kind of get the pattern recognition to see, okay, any population that happens here in this area is abnormal, and you can kind of focus in on that. I hope that answered your question. Also, very markers that really are commonly aberrant are 6C, 123, and 73. Those are my favorite markers and most likely to be abnormal. Usually at most institutions, CD10 can be way too bright. So usually your MFI maybe just off the charts or something. That could also be a clue.
Ok. Gracias, doctora. Tenemos otra pregunta. ¿A partir de qué viabilidad se invalida o se considera dudoso un reporte?
So if we get a viability lower than 80%, we put in a disclaimer. Obviously these samples are precious, so you don't want to just discard it right away. So we do it, but below 80%, we put in a disclaimer saying, you know, take these results with a measure of caution.
Ok. Tenemos otra pregunta que dice, hablando de el número de eventos a adquirir, para adquirir, ¿cuál es el mínimo de eventos para adquirir en un inmunofenotipo para diagnóstico? ¿Y cuánto para una edad mínima residual?
So for a diagnostic exam, say, I want to see, like, morphologically see about 10% less at least. And then for our diagnostic assays, both for our lineage assignment and our MRD diagnostic, we do 20,000 events. And then for MRD, our sensitivity is 0.01% for BALL and TALLs and 0.1% for AMLs. And we usually, or our sensitivities are calculated from 100,000 live mononuclear cells. So at least that much, but each lab has to do their sensitivity or their validation for their own thing, but that's roughly how much.
Ok, gracias. Otra pregunta nos dice, ¿hay alguna condición en las muestras que alteren tanto el marcaje como el análisis por citometría? Sabemos que hay varias condiciones, pero ¿cuáles son las más importantes o las que hay que tomar más en cuenta?
Blocking agents, for sure. Like bovine blocking agents, like BSA with PS is really good. And I think especially if you're going to do a surface and cytoplasmic tube together, you should do at least 2 buffer, if not just 1 buffer, blocking step, and your washing process, and washes post, washes in between each of the stains. Like, you want to make sure that you're not, I've seen labs kind of do a very aggressive washing process, so you can lose a lot of cells that way as well. So the washing kind of has to be gentle. The lysing has to kind of be gentle but complete. But the blocking should be a blocking step is, I would say, the most important.
Ok, gracias. Gracias, doctora. Aquí hay otra pregunta, si tenemos todavía oportunidad. Dice, ¿los paneles utilizados en su hospital están sustentados por algún organismo o están diseñados en base a la experiencia que ustedes han desarrollado en todo este tiempo?
Yes, they're designed by the experience that we've had at St. Jude. They're very St. Jude specific, the panels that we use for in our institution. The other panels are just panels that I've suggested with 2 other labs that we work with that might have like different supply chain issues, like BD won't give them certain antibodies, or in their hands, it certainly didn't, it didn't work well. Also, we don't use TSLPR for the CRLF2 in our MRD panels, but we do have it in our diagnostic panels. So sometimes, because of the frequency of CRLF2 rearrangement might be more or higher in other populations, I might suggest to use that marker in their MRD panel per se. So yeah, so at St. Jude, we do it just by our own experience. This is how we've done it. And then the panels that I showed, like the limited panels, are just panels that I've suggested to other institution or alliance members that I've worked with.
Ok, doctora, muchas gracias. Otra pregunta, dice, en relación precisamente a estos paneles, ¿están ustedes en vía de hacerlos, patentizarlos o registrarlos como paneles que se puedan utilizar en otros laboratorios o en otros países?
No, we have thought about sort of getting someone to lyophilize a tube so that it's like one tube with all of the markers in itself, so you don't have to pipette each and every marker separately. But we haven't patented it. This is this is just St. Jude's panels that we use. It's slightly different from the COG approach. And it is also slightly different from the Euroflow approach. And so those are more patented out of the box. I don't know if that answered your question. I'm sorry.
Sí, de acuerdo. Lo entendemos y sí, nos responden adecuadamente. Hay otras 2 preguntas, no sé si hay oportunidad de hacerlas. Una de ellas, pues básicamente es muy extensa, aquí está en el chat, pero nos dicen que en su experiencia, en su laboratorio, factores como mezcla de anticoagulantes, viabilidad disminuida, mucho debris o restos celulares. Es conveniente analizar la muestra o solicitar una nueva muestra, o se debe valorar con el contexto completo del paciente, la sospecha clínica, diagnóstica, la morfología para correlacionar con el resultado.
Yeah, so so in our experience, purple top tubes are the best for morphology, but they're not the best for flow. We like heparin tubes, and then even for, say, like high cellularity cases like CML or something like that, we'll use a citrate tube, which is like a yellow top tube. for cases that are clotted, like our lab will process EDTA tube if that was the only thing that we have. Say the clinicians didn't suspect it and I see blasts on a PB that no one suspected, then we will do an EDTA tube. But if it's clotted, we'll definitely ask them to just draw the PB again if it's easy like that. If it's a bone marrow, it's a little bit more difficult to tell them, go back. So we'll run it, but then if it's clotted, we'll put in a disclaimer. And you'll often see it even in your 45 side scatter. You'll just see like it's more neutrophils or more monocytes and lymphocytes, and you don't really see a lot of your left shifted elements. So for PB, yes, we'll just tell them to redraw. If it is clotted, we put in a disclaimer on our report.
Ok, doctora, muchas gracias. Nos preguntan también en el chat si ustedes tienen alguna publicación donde se encuentren enlistadas las clonas de los anticuerpos de sus paneles, o si hay algún lugar donde los podamos consultar para poderlos conocer.
Yeah, these two panels will be published shortly because these are just what we've had some experience with at a partner site, and so these two panels will be published shortly. But also, I'll be happy to share the panels that we use with you by email at all.
Ok, sería muy bueno. Muchas gracias, doctora. Y otra pregunta relacionada a este tema de los 8 colores, todos los paneles que hemos visto, que ustedes trabajan con 8 colores, ¿han estado pensando o analizando en extenderlos a 10, 12 colores o migrarlos a estos mismos paneles con la finalidad tal vez de optimizar o en sí no se siente eso?
Yeah, I think less the more colors you have, the less tubes and the less technical complexity you have. So yes, I would say for sure, the only thing you want to sort of be aware of in those situations is you don't want like two monocytic antigens on like too close to each other. So you want to kind of separate out your lymphocyte antigens and your myeloid antigens, and like not right next to each other, just maybe like 1 fluorochrome apart. CD34 can be quite finicky, so you want to not put it on a BB channel if you can. But yeah, I think the more colors you have and the less tubes you have to do is ideal for your lab, if you can.
Ok. Y bueno, hay algunas otras preguntas, pero por cuestión de tiempo solo quisiera aprovechar y hacer yo una pregunta, doctora, si me lo permite. En el caso de linfoblástica Philadelphia-like, ustedes, por el tipo de población que sabemos desde un punto de vista epidemiológico, clínico, que es en más niños de origen latino, ustedes introducen también los marcadores para la leucemia Philadelphia-like, hablando de la correlación citogenética con la fenotípica, y nos recomendaría que en México también se pudiera utilizar el marcador para correlacionar con Philadelphia Like.
I think that's twofold. So Philadelphia positive or BCR-ABL rearranged disease can be, you can either have BALL crisis, you can have AML, like myeloid crisis, CML, and you can also have MPAL with BCR-ABL. So really, when you're thinking about Philadelphia positive, you're going to start with that lineage panel anyway. You have to decide whether it's B, myeloid, or MPAL, for sure. Then I think as a second check, say you have BALL, but it's a super high WBC count, which is uncommon in BALL, then yes, I would recommend things like CD33, CD123 to decide if it does, if you want to, not only will it help you follow it in the future, but it'll help you say, okay, this is the one I'm going to send for BCR-ABL testing.
Okay. Bueno, pues muchísimas gracias, doctora Kumar. Quedaron algunas preguntas y creo que ha generado bastante interés. Agradecemos muchísimo el apoyo de Rita, de Judy Holmes, quienes han coordinado la realización de esta conferencia, y quisiéramos pedir si en el futuro podamos tener otros contactos con usted, ya sea otro tipo de reuniones, participar en más eventos del proyecto ASI de leucemia pediátrica en México.
For sure. I think, I mean, I think the type of consensus you're trying to achieve is really good. And I think it'll be really great for your region, and any way I can help. And, you know, this was just diagnostic. And so we can talk about minimal residual disease, DNA index. We can talk about how to report certain things. And I can, we can definitely look at making it like a seminar series, and I can participate in any of the panels if you guys have specific questions too.
Okay. Pues muchísimas gracias, doctora, y pues no sé si la doctora Arriaga, quien es la coordinadora del proyecto, quisiera al final.
Thank you very much, Dr. Zárate. Thank you very much, Dr. Kumar. We are very pleased and very grateful for sharing with us this marvelous experience that you have at St. Jude. Shortly, certainly, we will contact you to have more interaction, because as for you at St. Jude, for us is very important, first the children, and then all the science that we can use to help them. Thank you very much.
Yeah.
Okay,
Gracias a todos y a todas, de verdad, doctor Zárate, muchas gracias por esta coordinación, y le doy a usted la palabra para cerrar.
Muchas gracias, pues agradecemos a la doctora Kumar. Doctor Kumar, muchas gracias, y gracias a todos por estar presentes en esta interesante conferencia de la citometría de flujo de diagnóstico en leucemias pediátricas, la experiencia del Hospital St. Jude. Que tengan muy buena noche. Gracias. Hasta pronto.